The topic of today's lecture is thoracic imaging. So let's get on with it. So the topic is non-traumatic chest wall imaging. Now it is non-traumatic because traumatic injuries will not be included. They are included in a separate lecture. Now during chest wall imaging, which is non-traumatic, we use various kind of modalities from simple chest x-ray to CT scan to MRI to variety of other modalities that we will discuss. Now, which modalities to select, in which we will go by example. So, the first one to consider is an infectious pleural disease. In an infectious pleural disease, the modality of choice is a standard chest x-ray. A standard chest radiograph is what we use when we suspect on the physical exam that some kind of infection is going on in the thoracic cavity. Now on this chest x-ray, what we will find? Two things we will find. One, pleural effusion. Two, consolidation, cavitation, or some kind of necrosis. These are the things we'll find if infection is present. Now, in case of pleural effusion, we have two kinds. Either it will have meniscus, which is usually found in infection, and the pleural effusion is serous due to that infection. This kind of pleural effusion is usually found in pneumonia. Other kind of pleural effusion that we may find on the chest x-ray is the loculated type. Now this type of pleural effusion is what we usually find on the empyema. Now chest empyema is defined as the presence of pus in the chest cavity. So an infection can result in both serous pleural effusion and empyema, or the presence of pus in the chest cavity. Next example would be costochondritis. Now costochondritis is defined as the infection or the inflammation of the cartilage that connects the sternum to the rib cage. Now it is very important because in this example what we do is we do both plain chest x-ray and we do CT scan, but both of these are usually not diagnostic. They do not confirm the disease, though disease is found on the physical exam when the pain is central and symmetrical, but it is confirmed on the PET scan. Though during the course of the treatment, CT scan is more preferred because we want to evaluate how our treatment is going for the costochondritis. So we use CT scan to diagnose, we use PET scan to confirm, and then we use CT scan to evaluate our treatment. Our next example would be chest wall masses. Now these chest wall masses can be malignancies. Now these malignancies will be discussed later, or they can be simple lipomas. Now in case of masses, either they're painful or they're not painful, CT scan is always preferred. Now this CT scan can be both contrast enhanced and non-contrast enhanced, but it is CT scan that is used. But if the mass is a lipoma, now lipoma is diagnosed by being more mobile and having a more ovoid shape, and ultrasound will be more favorable. Now if we have tumors in the chest wall, so there are two kinds of tumors, the benign tumors and the malignant tumors. Now, the benign tumors in the chest wall are chondroma, osteochondroma, and fibrous dysplasia. These are the only benign chest wall tumors. Around 50% of malignant chest wall tumors are sarcomas. Examples would be osteosarcoma, Ewing sarcoma, even lymphomas, myelomas, osteoblastomas. They make up the rest of the 50% of the malignant tumors of the chest wall. Next, we have the thoracic radiculitis. Now, radiculitis is defined as having nerve root compression. Now, there is some kind of problem in the vertebra or around the vertebra which is causing the nerve roots coming out of it to getting either entrapped or compressed. Now, this results in a variety of symptoms, but all of these symptoms make up the radiculitis, and thoracic radiculitis is no different. And thoracic MRI is the modality of choice to be done in this condition. Next, we have a few examples. The loculated pleural effusion. Now, this is a lateral chest X-ray. As you can see here, this area is the loculated pleural effusion. It is loculated because it is locked in its position. It is not moving, it is not fluid, it is focused, it is locked, and it is present in its area. It might encroach upon the parenchymal tissue, but it will not move along the pleural cavity. This is the defining characteristic of a loculated pleural effusion. A serous pleural effusion will move according to the gravity and according to the pleural space. This here is fixed in space. You can see by this convexity. If it was serous, there would be no convexity here. It would be along the margin of this diaphragm. But since it's loculated, it is locked with a convex shape. Next, we have the metastasis. Now, all primary tumors of the chest wall, especially the malignant ones and the blastomas, have the capability to metastasize in the same area. Here an example. Now, here a malignant tumor has invaded, encroached, and destroyed the sternum. And this sternum here on this CT scan describes what an encroached metastatic malignant tumor would look like. For reference, this is an example of a metastasized breast cancer. As you can see, the tumor infiltration of sternum is very, very bad, and it is very infiltrated with a lot of irregularities and a lot of focal points. Next, we have the radionuclide bone scan. Now, a lot of metastasis in the chest wall can be detected by doing a radionuclide bone scan. Now, if you cannot find, now there's some metastasis in the chest wall, but the primary tumor cannot be found, usually a radionuclide bone scan is recommended because, as I said earlier, 50% of malignant tumors of the chest wall are sarcomas, that they are composed of the connective tissue. They come from cartilage or bone. So a bone scan might reveal where the primary tumor is, where it has metastasized along the rib, and as you can see, it has also metastasized to the left scapula. Next, we'll be studying about the cardiac disease and its various modalities. Now, cardiac disease is a very, very specialized topic, and usually patients with cardiac problems come under the care of a specialist, a cardiologist. But what kind of imaging do they require? Now, this is something that comes under the umbrella of radiology. Now, any patient with a cardiac disease, acute or chronic, first the normal test, the normal cardiac workup is done, which is composed of the ECG and the echocardiogram. The ECG is the electrical activity of the heart, which is sensed through the skin. The echocardiography is basically the ultrasound of heart in motion. We can study both the ventricles, the valves, the major vessels, the aorta, the superior and inferior vena cava. Then we have the radionuclide myocardial perfusion studies. Now, in these studies, also called ventilation perfusion studies, we can find out how much air and oxygen is coming to the body inside the lungs, how much is being perfused by the heart to the body. Now, in these studies, we can find out how much the heart is compromised, what kind of disease it has, even if it is having some kind of a problem. We can rule out the cause being cardiogenic or non-cardiogenic through a simple VQ scan. Another modality that is used for cardiac diseases is cardiac catheterization followed by angiography. Now, this is a very invasive procedure. Now, what happens is when you have a patient with a rapidly developing ischemic heart disease, let's say ST segments are elevated, TROP-T are positive, CKMB is positive, that patient must be catheterized. That patient should not be imaged first and then catheterized. That patient must be catheterized first, and then angiography through a dye should be performed. And that angiography will give the idea that how much of the coronary circulation is compromised and how much of the coronary circulation is intact. So, cardiac catheterization and angiography go hand in hand, but only in those patients where ischemic heart disease has clear-cut symptoms like elevated ST segments, CKMB, TROP-T positives, everything. Next, we have the cardiac CT. Cardiac CT is performed in those patients, those who have either unstable angina or those which do not have ST segment elevation, in which we do have time to perform the image to confirm the state of the heart, how the heart is performing. In those patients, cardiac CT and MRI is performed. Now, this gives us a very good idea how much the heart has been compromised or how much the heart is working. But in cardiac diseases, the normal battery of tests, as I mentioned earlier, these are not the only one. There are certain tests which are called risk assessment test. One of those is calcium scoring. Now, calcium scoring is a risk assessment test which tells us how much the heart and its circulation is compromised and how to proceed with it. Because this modality gives us a specific score, as the name says. So according to that score, we choose the treatment methodology. Now, MDCT here stands for multi-detector computed tomography, and calcium score study report means the calcium score. Now, this is how it is performed. Now, what happens is that we use a multi-detector CT and use low dose X-rays to only visualize the calcium that is present in the atherosclerotic plaque in the coronary circulation. And that low dose CT X-ray give us a score in all three of the coronary arteries. There are three coronary arteries: the right coronary artery, the left descending artery, and the left circumflex artery. Here, as you can see, the score is given both for the left one, the left circumflex, the left mean, the left descending, and the left circumflex. And the total score is given here. That is 581.39 for this particular patient. Now, if the score is less than 40 or even 0, it does not mean that the risk is also 0. It just means the risk is reduced. Now, if the score is between 40 to 800, that means the score is of moderate level. That means the patient might go and undergo stenting or might not go into scanning, but that patient is not a candidate for CABG or coronary artery bypass grafting, meaning that patient has moderate stenosis in his coronary artery, and that patient should require only either balloon angioplasty or some kind of stenting to keep the vessel patent, or some other method for revascularization, but that patient does not require grafting. But if the patient has a calcium score of more than 1000, now that patient, or if the patient has a triple vessel artery disease, TVCAD, then that patient is a candidate for CABG. This scoring is what we called risk assessment. Now, one thing should be pointed out here, that risk assessment, like calcium scoring, is no alternative to regular modalities like the perfusion scan, like the echocardiography or the therium scan or the cardiac CT or the MRI. These are the risk assessment studies which actually just point us to which methodology of treatment to use, to which plan of treatment to use. They do not give a definitive diagnosis. They only assess the risk of diagnosis. They confirm the diagnosis and they give an overview of how to proceed with that particular patient. Next, we have CCTA or coronary CT arteriogram. Now, it must be noted that this is an arteriogram, not angiogram. Angiography is an invasive technique. Arteriogram is not an invasive technique, though it utilizes a multi-detector with multiple slices. It is more extensive than the calcium scoring. It is still an risk assessment technique. It is by no means a definitive diagnostic modality. In CCTA, what we do is that we use an iodinated contrast, and that contrast is then circulated throughout the heart, and multitude of pictures are taken, and all those pictures through CT scan are taken, composed, and an idea is given of how those vessels look. An example here would be like this. This is an image generated by CCTA where the iodinated contrast was introduced, and then CT scan imaging was done. Here, as you can see, this vessel here is the right coronary artery, and as you can see, it's normal, it's patent, blood is flowing, there's no problem with it. So it's a normal CCTA image. This here though is the thick layer of pre-sternal fat, so it has nothing to do with blood. This is the lumen of the RCA. Now, the beauty of CCTA is not only it assesses the risk, because multiple slices are taken and a lot of information is taken during the study, we can actually produce a volume rendered display. And that volume rendered display through a non-invasive technique is not only beneficial for the doctor, but it also is beneficial for the patient, because patient can better visualize his problem. He can better visualize what kind of treatment along with his doctor he's gonna take. So in this image, which is volume rendered, this is the left descending artery, and this one is the left circumflex artery. Now the main circumflex artery is suffering from severe stenosis at this point right here. Now if we had used an invasive technique, well, we might have taken a good view, but it's a non-invasive technique, and through it we have found out what exactly is wrong with our patient, what kind of cardiac problem he has. He has a severe stenotic problem in his left circumflex artery, the main body of it. So the treatment plan gets easier. The next two slides show how it can be done. This is the coronary arteriogram of the same patient. This is the left descending, this is the RCA, and this is the circumflex. And this was that severe stenosis that we saw earlier. Now, if we just perform balloon angioplasty, a balloon is inserted, a wire is inserted inside the stenosis, and a balloon is slowly swollen up to break the plaque and revascularize the artery. This is what is called balloon angioplasty. Now, through balloon angioplasty, this severe stenotic area has been cleared here. Now, this is the same area of the same patient. The only difference is that instead of invasive technique, we used a non-invasive one, and through that we knew exactly what to do, how to do, and the results are right in front of us. That the patient's revascularization is complete. There is no need for stenting, there's no need for bypass grafting, only balloon dilatation has done its part. So CCTA is gaining slowly and rapidly both gaining popularity, and it's going mainstream. Now, instead of having complex angiography or catheterizations and all those, we can simply perform CCTA and we know how to proceed from there. Such example is given here. Next, we have acute chest pain. Now, what is an acute chest pain? A patient with pain which is radiating or coming from his anterior wall, maybe radiating to his left or right arm, maybe radiating to its abdomen, and there is no suspicion of any cardiac activity, that is termed as an acute chest pain. So if there is no suspicion of any coronary event or cardiac activity or any coronary event, then this is termed as an acute chest pain. Now, for an acute chest pain, where the heart is not the problem, where an ischemic heart disease is not the problem, the modalities that we are going to use are a standing chest radiograph, a simple standing chest x-ray. Now, this might give us some idea that what is wrong with the patient. He might have some pleuritic pain. He might have some muscular pain. He might have some kind of skeletal pain. So, the first thing we do is a normal chest x-ray. Next modality that we might use is a CT angiography, because the pain might be due to some kind of problem with the vasculature. Now, if the problem is with the vasculature, an angiography is the best way to examine it, diagnose it, and deal with it. Next, we have the MRI or the MRI. Now, this modality in an acute chest pain is used when the origin of that said chest pain is non-cardiac. It could be aortic dissection, it could be aortic ulceration, or it might even be coronary occlusion. So all of these can be visualized and diagnosed through MRI. It's only a matter of perspective and selection on the part of radiologist. We also have the availability of a transesophageal echocardiograph. Now, echocardiography is basically ultrasound of the heart in motion. So when we perform the normal echo, it is actually transthoracic, that is, you are doing through the chest wall. But there are few instances where we can perform echo through the esophagus, where actually the piezoelectric crystal or the probe is sent downwards through the esophagus like an endoscope, and then the echocardiography is performed. It is more accurate than transthoracic one, but it is also more cumbersome. It requires patient to have some kind of sedation or anesthesia, and it is only good in few of the instances, like the valvular diseases. Valvular diseases are better visualized in a transesophageal echo. In a transthoracic one, all the other problems can equally be visualized. Next, we have the SPECT myocardial perfusion imaging. Now, SPECT stands for single photon positron emission tomography. Now, what happens is that this is a very specialized modality, and it is only used in very, very few circumstances. It is used in those conditions where we could not find out how the perfusion of the patient is compromised. The coronaries are good, the ventricles are good, the heart and the muscle is good, the tissue is good, but there might be something someplace that is compromised, that is wrong, that is abnormal. It might be a tiny mass or nodule. this can be picked up on a SPECT perfusion imaging study. So next we have the AP radiograph. Now, one of the common culprit of an acute chest pain is a pulmonary embolism. Now, during pulmonary embolism is a very life-threatening condition, but it also produces a very typical chest X-ray, which is called wedge shape. The consolidation here which is produced is always wedge shape. So if you see a wedge shaped consolidation in your simple chest X-ray, always consider that pulmonary embolism is in play and rule out pulmonary embolism either by ruling out DVT and performing the D-dimer test. Here is the peripheral wedge-shaped opacity. Next, another culprit for an acute chest pain is aortic dissection. Now, aortic dissection is the one where what happens is there are multiple layers of aorta. There's the intima, media, and the externa. Now, what happens that blood starts to come between the layers. It starts to dissect or separate the layers. And this dissection of aorta is what we call aortic dissection. Now, this is usually very painful condition, but it can be life-threatening because it can turn into an aneurysm, and that aneurysm can burst at any moment. So in order to visualize it, we use a CTA, a angiogram. Now here we have the axial CT. This is the ascending aorta and this is the descending aorta. And this here is the septal wall in which the blood has encroached and is flowing and is pooling here. So this is a false wall, and this is what is causing the aortic dissection. So this is the elevated intima, the false wall, everything. Next, we have the chronic chest pain. Now, chronic chest pain is defined as pain from your chest, either anteriorly, posteriorly, laterally, which is either intermittently or through regular intervals, regularly or irregularly, happening for a long time. So there is no pet or set definition for a chronic chest pain. It just means the pain that is regular or irregular, frequent or non-frequent for months or days is termed as chronic chest pain. And sudden start of chest pain is termed as the acute one. One of the most common cause of chronic chest pain is asthma. Now, asthma is described. Asthma usually presents with a simple plain chest X-ray. There aren't usually any signs. The margins are okay, the fields are okay, the bones are okay, the vertebral column, the trachea, esophagus, heart, diaphragm, the air in the stomach, everything is normal. Yet for an asthmatic patient, the diagnosis is mostly physical one. An asthmatic patient is usually diagnosed on his physical exam. That is his inability to breathe. That is what is diagnosed through a physical exam, but it is the most common example of a chronic chest pain. Because during an attack of asthma, patient suffers from what is like a congesting, contracting pain, and it can be very severe. Next, we have the chest CTA of multiple areas. Now I will describe. Now this here is the vasculature of the mediastinum, and all of it is expanded due to aortic aneurysm, aortic dissection, and chest CTA is confirming all of this aneurysm here on all four of these confirms that this patient is suffering from chronic chest pain. Next, we have the congestive heart failure. Now, congestive heart failure is diagnosed on PA chest x-rays. There are usually no requirement for CT scans or MRI. Why? Because there's a set of very certain changes that happen in the x-ray. One of those being that there is an increased left atrial pressure. So there is increased left atrial pressure, so mean there is an increased pulmonary venous pressure, and that increased pulmonary venous pressure causes the vein in the upper lobe of the lungs to dilate. This is not what usually happens. Usually the veins in the lower lobe of the lungs are dilated. Why? Because of the hydrostatic pressure, because of gravity. But in a congestive heart failure, where the heart is congested because of the increased left atrial pressure, the veins of the upper lobe are dilated, and these dilated veins are pathognomic of congestive heart failure. You can also see, because of the congestive heart failure, the patient also has cardiomegaly, but it's mild. Next, congestive cardiac failure also results in what is known as edema along the interstitium of the lungs, and that edema along the interstitial lines of the lung results in the certain lines which are called the curly B lines. Now, curly A lines, curly C lines are also observed in the CHF, but they are not usually observed. What is usually observed are the curly B lines, and they are due to the edema along the interstitium of the lower lobe of the lung. Another pathognomic feature of congestive heart failure is the pulmonary edema. But this pulmonary edema has a very peculiar shape, as you can see here. This haziness here on the left and on the right is due to pulmonary edema, but this is centralized. It is not peripheral, it is not apical, it is not inferior. It has very central winged like appearance, so it is called bat wing appearance. So bat wing edema or bat wing pulmonary edema is again pathognomic of congestive heart failure. So there are three things which are found if a person is suffering from congestive heart failure: bat wing style pulmonary edema, curly B lines, and the dilated upper lobe veins. So what we learned today? We learned about the chest wall and various modalities that we will use in it. What modality we'll use if it's an infection? What modality will we use there if there's chest wall mass? What modality will we use if there is a malignancy or if there is metastasis? Chest x-ray to use in infection, CT scan to use in malignancy, or MRI to use when there is radicolitis. We learned about this. Then we learned about the heart. We learned about the coronary events. We learned about what happens during the various modalities of the cardiac tests. They are the regular ones, the normal cardiac workup, the ECG, the echo, the cardiac MRI, CT scan. We learned about those. We learned about the VQ scan. We learned about the risk assessment studies. Now, these were the important one where we learned about the calcium scoring system. We learned about the CCTA, the arteriogram. We learned how important it is, how non-invasive it is, and how much we can gain from this simple test. Now, instead of regular angiography, we can simply perform a CCTA and we can judge that which treatment plan to follow. We also learned about the acute chest pain. What are the usual suspects for an acute chest pain and what are the usual suspects for a chronic chest pain? From the coronary MI to the asthma, we also learned about the congestive heart failure. We learned about how to diagnose congestive heart failure on simple chest x-ray. The three things that are pathognomic for CHF: the dilated apical veins, the batwing edema, and the curly B lines. We learned all that about the chest wall, the heart, everything. I hope you enjoyed this lecture. Thank you so much for watching sqadia.com. Thank you.